Once again, I want to thank the organizers for giving me this opportunity to share a few things across Sub-Saharan Africa. Those are my disclosures. In a couple of minutes, I'll try to we'll give an overview of diabetes, changing the landscape across Sub-Saharan Africa, the complications that we see commonly among these patients, and a take-home message. All types of diabetes are familiar with, and you've seen this map presented before. This is much earlier. This is in 2003 IDF, and you can see that diabetes across Sub-Saharan Africa is relatively low. The prevalence virtually in all places is less than 10. However, a few years later, now we are looking at the recent atlas, we've moved to a prevalence where the prediction is an increase of 134%. We've recently done studies in Uganda, and I'll be coming to that, and there are other step surveys across Sub-Saharan Africa which show that there is an increase in diabetes, in all types of the diabetes. We are now not looking at type 2 alone, but other forms of diabetes are quite increasing. Now, what's driving this? There are messages that we should stop diabetes. What's driving the diabetes, despite that we say, please stop going ahead with diabetes? In 2021, an estimate was 24 million adults. That's mainly, those are type 2 diabetes, but as we've already seen, they may also include other forms of diabetes. And the IDF atlas normally takes 20 to 79, and that's usually because they also depend on the step surveys. We're living with diabetes in IDF region, in the IDF Africa region, which is almost mainly Sub-Saharan Africa. There is a rapid rise. IDF consistently emphasizes the rapidly growing incidence of type 2 diabetes in Sub-Sahara. And the message is, let's not increase our weight, let's stop. And already the message has been put on the wall. It's not only those who are heavy that actually develop diabetes. What are the challenges over the past years, and that's why the landscape for diabetes is changing, is that we've got HIV/AIDS coming on the scene, and we now know that HIV/AIDS is associated with an increase in diabetes, and some of the drugs themselves are associated with an increase in diabetes, particularly those which have retrogravir. And then there are complexities. There are overlapping epidemics, NCDs, HIV/AIDS, with limited resources. There is stigma and discrimination, and there is rapid urbanization. This is a bar chart, not a bar chart, but a pie chart that I presented a few days ago, showing that we tried to characterize diabetes in Africa by doing cluster, and we've just looked at a cluster by Dr. Jones. When you use the cluster analysis for Europe, it doesn't fit very well for the African population. When you use the parameters, particularly those related to the Sub-Saharan Africa, and here we are looking at Ghana, then you'll find that the obesity and age-related still take a big chunk. But then there is a small chunk of malnutrition-related diabetes, which is here, which takes a good 7.9%. Then there is that ketosis prone. And then there is the last one, which is the body fat related and insulin resistant. Now these, to the clinician sitting in the primary health care, pose a big challenge. What do they mean? Do they have the same complications? Is it just the pattern, or is it just the phenotypes? Now, this is a very busy slide, and the data has not yet been published, but I will guide you as to what I'm after. This is the STEP survey of Uganda done in 2014, and a repeat done in 2023, 9 years later. Now, I want you to focus here. If you look at 2014 and 2023, you will see that the prevalence overall was 2.2 in the general population. That is the population data. And it rose to 3.8 in a period of 9 years, using the same methodology in conducting the studies. If we look at females, they also increased from 1.3 to literally double, 2.5. And if we look at the males, 0.9, it's still almost doubled to 1.4. So while it is low in one area, it still doubles in another area. And that's the landscape we are seeing, that there is an increase in diabetes. And what is driving it? What is driving the diabetes? And this is where the age group actually comes in. Our people haven't really doubled in age at that time. They only moved 9 years from one end to the other. And we still took the same age group of 18 to 69. But we can see that in that age group, still there is a doubling of the prevalence of diabetes, most of it being type 2. But our later analysis shows that even those who were lean actually increased in number. And how about urban and rural? If we look at urban and rural, 0.3, 0.4 in the young people. So if it was actually people migrating and the urban areas being cause of diabetes, we should also be getting it in the younger people, but there isn't any change. And yet we know that the urban areas actually increased or almost doubled in Uganda, or people who were living in the urban areas. So this is the scenario, this is the changing landscape, this is the pattern of diabetes we are going to be facing in Sub-Saharan Africa, a rapidly increasing diabetes. Is it remaining the same? Is still a question we have to answer. We still have to go and look inside. I hope my friend will be able to answer the question of phenotyping these people as they move, as they change from one year to another year. Are we still remaining with the same type of diabetes, or are we just dealing with the numbers that increase? Here I'm looking at the waist to height ratio, and it's the one which could tell us much more about the increase in the diabetes. Indeed, the weight-height ratio did increase in these people. So there was an increase in weight. But the question is, if someone is thin and has diabetes or unlikely to develop diabetes, if he increased by a delta X, as we say in mathematics, does it predispose him to diabetes? And these are the questions we still yet have to answer. Now let me go away from type 2 diabetes to type 1. Again, type 1, has been talked about quite a lot, and I have passionate for type 1 because when we started type 1 diabetes management in Uganda, we only had 120 patients in 2 main hospitals. And in a period, again, of about 20 years, we've seen not a doubling. Now we have 5,000 patients on the register, and that's a huge number. One can say, yes, we're losing them from, they were dying before diagnosis, but that may not be the true story alone. The figures here is the quote from 1.5 to about 10, depending on the country, depending on the age of which you are looking at. And that is the landscape of type 1 diabetes. But what do we see in type 1 diabetes? Again, that's a very busy slide, but I'll take you through that. Phenotype of type 1 diabetes is poor understood. And there are several studies which have come out, and the one recently is of Kati and group, which shows that even in type 1, there is what he believes is, the group believes, is a typical type 1 diabetes. Whether that's what we are looking at as lean type 1 diabetes is still yet to be understood. We have a bimodal incidence peaks, 5 to 6 years, which is a very small peak, the majority being 18 to 20. And that's why our belief is that we have not been missing all the diabetes as the projections seem to suggest. More actually, we may be missing the adults who are getting type 1 diabetes, but are they all of them type 1 diabetes? Because the islet antibodies have a lower rates. We did islet antibodies in Uganda, and again, they were very low rate. We did HLA, and we find that it's HLA-3 DR3 and not HLA DR4. Poor control and complications are early, unfortunately. I think something else can be done, but that is the pattern we are going to see. We're going to see in type 1 diabetes and a typical form of type 1, antibodies not easily found even when you actually see them very early. HLA typing, much as it is expensive and not done everywhere, will give you slightly different parameter than you find in Europe, and then at the end of the day, the control is going to be poor. Having said that, we should not forget that not all of we see with requiring insulin is actually type 1 diabetes. We have 3 patients with neonatal diabetes. Interestingly, all of them detected or diagnosed by nurses. And they are alive and well. We have had their genetic mutations done, and they are all clearly neonatal diabetes. One is controlled on tablets, 2 others are on insulin. MODY, again, this we find in the several studies that have been published from Uganda and elsewhere, where we do find MODY. Again, this diabetes is hardly well characterized in Sub-Saharan Africa, and we see that it goes on. Sometimes they treat them as type 2, sometimes as type 1, depending on whom they have seen and in what way they present. So we've just looked at those increasing and challenges, type 1 diabetes and type 2. Let's look at the other one now. And that's diabetes in pregnancy. These are younger people, and the prevalence has varied. When we get someone working on it, depending on what methodology they have used, we get a different picture. Gestational diabetes in Sub-Saharan Africa. We have got several reports, many different protocols with the lack of uniformity between countries and within countries have been giving us different forms of prevalence and different forms of outcome. Prevalence of GDM in Sub-Saharan Africa using the WHO 1999 criteria was about 10.4 versus 4.5 using the WHO IDPSG in 2013 criteria. And there are various references which allude to that. So what are the complications? Patients are diagnosed late, and many present with complications before diabetes is detected. That's the spectrum. Unfortunately, I hope that will improve. What are the complexity and the complications? Undiagnosed diabetes, the prevalence of undiagnosed diabetes in Sub-Saharan Africa is high, with an estimated 54% in a recent systematic report, with diabetes unaware of their condition. In Uganda, the recent one, we have approximately 42% unaware that they had diabetes and just detected on capillary blood at screening during the STEP survey. Many will present with complications, and again, there are several studies which have been done here. The older one is by my colleague Nambuya, and sepsis is a common presentation, even at first time, because we are almost having half of the people with diabetes in Sub-Saharan Africa not knowing what has happened until they get complications, followed by malaria, tuberculosis, HIV/AIDS, and pancreatitis. Peripheral neuropathy was present in 46.4%. That means that it's actually, they were staying there for quite long. Hypertension is common, and with blood pressures as high as 150/100 in 27.3% in one of the series, and impotence among men. Proteinuria is common. Again, it's not surprising if they are going to present with hypertension and present late. Ischemic heart disease and foot ulceration and cataracts. The management is poor. Management of diabetes falls short of the guidelines. Again, there is a paper, Tabitha and others, 2019, showing that actually hardly the new drugs are being used and hardly anyone gets below A1C of 7. There is poor control. Average was 9 in one of the series. So what is my take-home message? Simple. Diabetes in Sub-Saharan Africa is heterogeneous, as the people are heterogeneous and rapidly changing. So we need contextual studies to look at the diabetes that is changing. Are we having the same diabetes after this evolution, or something else is driving it? Thank you very much, and thank you for your attention.
Thank you, Professor Bahendeka. We'll take the questions during the panel discussion. Thank you, sir.
Thank you. Thank you, Philip. It's a pleasure being here and to be back to CMC after many years. And my talk is going to be about how we can make an impact on diabetes in rural India and some of the experience that our institute has done. Ours is a tertiary care institute in India for diabetes, but we have a rural diabetes care project, which is what I would like to speak about. So this is my disclosure. I looked through my old papers and I suddenly found my employment ID card of CMC Vellore. I think this was in the mid-90s. And when I showed it to somebody, somebody made a wisecrack. They said that, Unni, you're supposed to return this card when you leave any institution. Most colleges ask you to return it once you finished your tenure. So I said, okay, if I've left the institute only, then I need to return it. But I'm still in Vellore. You can take CMC, you can take a human out of CMC Vellore, but you can't take CMC Vellore out of me. When I calculated, I've spent about 9 to 10% of my life in this wonderful temple of learning. And it's a pleasure to be here once more. And that's it then. Let me get on to the main topic, which is diabetes management in India. And it is a challenge. And the second part, I will talk about our experience in the community. And in the third, I will try to talk about how we try to design a way forward. So this is a paper I published showing that there are regional disparities in the prevalence of diabetes in urban India across many cities. If you take the nearest city, Chennai, the prevalence is pretty high. And also, if you look at the status of diabetes care in India, you will see that the average HbA1c of people with type 2 diabetes is about 8.9%. So clearly we can do more. And these are some pictures from our outreach program. This is, we have our mobile diabetes clinic program. This is a mobile diabetes clinic. It is equipped with a medical officer, a fundus camera, a biotissuemeter, a handheld Doppler, and we have a hub and spoke pattern where the vehicle goes to a small village, comes back to the big village, next day goes to another small village and comes back. And when one cluster of villages are over, the vehicle migrates to another one, and we take a house on rent for the mobile outreach staff to live in each hub. And this is one of the gentlemen who came to visit our mobile clinic, and you can see that he has an amputated foot. And instead of offloading, people with diabetic foot ulcers are supposed to offload their foot and not move the feet, but he's clearly been walking. He's used a plastic net to tie it up, and therefore you will see that the care of diabetes in rural India is actually quite dismal. So the problem of diabetes in rural India is not just about access, it's about awareness, it's about trained personnel, it's about cost, and like any type of diabetes, half of diabetes in rural India is undiagnosed. So we could go ahead and screen all the population in rural India. Let's screen everybody with a glucometer. But that is not just expensive, it may not be feasible, but the low-hanging fruit which we attempted is to take people at high risk and then screen them for diabetes. So we used a diabetes risk score, and we modified that risk score with several other aspects which are common, like polyuria, polydipsia, vision problems, foot problems, and we found that with that we were able to detect diabetes better. And of course, there is a special role of diabetes in women because the polycystic ovarian disease starts in puberty. In adolescence, women have gestational diabetes and postpartum weight gain. And then they go on to develop menopause and they lose the protection of estrogen, and diabetes itself takes away the protection of cardiovascular disease. And of course, you have an effect of age. So when we analyze this, our data of obesity, abdominal obesity in rural men and women based on waist circumference, we found that about 30% of women and 35% of men have high waist circumference, and this is data on 29,000 plus people. And these are some glimpses from our mobile clinic. I don't claim to have gone to the mobile clinic every day, but I have visited the mobile clinic on many occasions. Our mobile diabetes clinic is equipped with a TV, and you can see that in the field, in the village, all the women are patiently waiting, but all the men are in a hurry to get themselves tested first. And that is also the story of our country or in any part of the world, because anywhere you go in the world, women are not getting guideline detected care. If you look at cardiovascular disease, they in India reach late for interventions. In many fields, they don't get guideline directed care, and you can see all the men coming in to take the treatment first, and then all the women waiting. Well, this is not a randomized study, it's just anecdotal experience. This is another little girl with type 1 diabetes in a very remote hilly terrain of India, where because of the lack of adequate supply of insulin, she was not getting insulin on time, and when her father used to bring insulin and when she used to inject it, she used to feel much better on those days. And so therefore, I've talked about two stories. One is the large numbers of people with diabetes and the regional disparities and the 8.9 HbA1c and the 77 million people with diabetes in India. And then I've looked at the small one or two cases, the individual aspect. I think whenever we treat diabetes, we have to look at the larger picture and also the smaller picture. And at that point, let me talk about our experience in the community. So we have employed community health workers called ASHA workers who go to each small village, and when our mobile clinic goes to that small village, she brings a cluster of patients to that small village for the mobile clinic to take care of, and then the mobile clinic is back and another ASHA is ready with a set of another patients the next day. So we have successfully employed community health workers for training in identifying diabetes and also in bringing people with diabetes to the clinic. And what we found is that this is the initial number. We've crossed many times this number now. We found that in the initial number which we published, just when we were piloting it, we found that our pickup rate for diabetes was about 20%. That means we were quite efficient in screening for diabetes rather than screening the whole population. This is a design of our mobile clinic, and you can see this is a registration counter of the mobile clinic, the examination, the blood test, the fundus camera, the foot assessment tools, and this is Dr. Dore, who is an expert in on-field interventions, and he designed this for us. And we were also mentioned by the Indian Council of Medical Research in their white paper that going to the villages and then detecting and making people aware of diabetes is always a good tool. And this is a paper on rural obesity that we published in 2020, where we found that rural obesity is by no means rare today, especially in the state of Maharashtra that I come from, which is one of the wealthiest states of India. You will know cities like Mumbai and Pune and Nagpur. These are all big cities in India from Maharashtra. And in this study, we found that the overall occurrence of obesity as per BMI is about 26%. We also excluded people with known diabetes and hypertension and tried to see whether this increase in BMI from 18 to 22 to 22 to 25 and above 25, we tried to see that if there was an association between the increase in BMI and the occurrence of newly diagnosed diabetes or newly detected hypertension. And we found that there was a statistical significance in the occurrence of newly diagnosed or new detection of diabetes, type 2 diabetes and hypertension with increase in body mass index. So there is a problem of abdominal obesity in the villages. There is a problem of obesity as per BMI in the villages, and the obesity is also associated with new or undetected type 2 diabetes and hypertension in addition to the detected burden. So what? What are we going to do about it? We know that there's a lot of diabetes in India. We know that people are suffering. We know that individuals are suffering. We know that the population is suffering. We know that the population's A1C is 8.9. We picked up diabetes in the village. We found there is complication in the village. We found a lot of them are obese. We found they have hypertension. So what are we going to do about it? And that is where I think we need to focus on, because in addition to talking about epidemiology and the problem of diabetes, I think we have to talk about what can we do to improve things. And that is how we designed our new project, which we completed a few years back, called Diabetes with Dignity, because one of the inspirations for this project was this paper I published in the Annals of Internal Medicine in 2016 under the leadership of Dr. Tandon. And this was done in both India and Pakistan in urban centers, including our center. And we had a care coordinator who would drive guideline detected care, which means if you have a patient in front of you and the LDL is, say, 130 and there's evidence of high cardiovascular risk, and if you're not starting a statin, the care coordinator would ask you Do you want to start a statin? Why don't you want to start a statin? If you're not starting a statin, why don't you write it down what the reasons are? So that sort of a push or a nudge, as you would like to call it, was quite effective in reducing the A1C as well as other parameters. So based on this very urban study, we sought to see whether we could replicate it in rural India as well. And therefore we embarked on this project called Diabetes with Dignity, where we trained ASHA workers. Till now we were training ASHA workers only how to diagnose diabetes. But now we started training ASHA workers how to train patients or people with diabetes about how to check their glucose levels, how to measure their BP, how to measure their weight, how to follow a diet, how to follow exercise, how and when to go to the doctor, and what is the importance of going to the doctor. They wouldn't prescribe medicines. Community field workers wouldn't prescribe medicine, but they would make sure that everything that's outside a doctor's chamber is done. And these community health workers would make monthly visits for a period of 6 months in that village. And how did we design this? So it's very difficult to randomize villages. So what we did is that we took a primary health center and took a cluster of villages around that primary health center, and we chose the primary health center in such a way that these two primary health centers are fairly similar, and that they are also quite far off from the urban hospitals, and they are also equally remote, so that they are matched for each other. And by a simple toss of a coin, we assigned one cluster of villages to the intervention arm and one to the comparison arm, and we looked at about 5,000 adults, and we aimed to take 300 subjects in each group. And in one group we would give monthly field worker based interventions every month for about 6 months, and the other group we would just give initial awareness and see the patient after, say, 6 months. So this is a quasi experimental study located in two different sets of villages, and to see what could be the outcome of not a doctor, not a nurse, a community health worker trained to impart diabetes care to the people. And we had a third party to evaluate us. We didn't do the study and evaluate ourselves and present it. We had the Public Health Foundation of India to actually evaluate this. And what we found is that, you see, the green color is the intervention arm and the blue color is the control arm. You will see that the A1C came down from 8.8 to 8.2 in the intervention arm, whereas it rose from 8.7 to 9.66 in the control arm, which is expected if you just diagnose diabetes and leave it alone and tell the patient, follow diet, exercise, go to your doctor. They're not going to do it. And one of the reasons for the improvement was not just the ASHA, the community health workers educating people about diabetes. We also went ahead and trained the primary health center doctor in that cluster of villages, and we also identified every doctor treating diabetes in that village and trained that doctor. We also involved the village health and sanitation committee in that village when we did it, so that we completed the loop of giving an ecosystem of better care, and you can see the results. And similar results played out with LDL also, and these were some of the papers we published. Interestingly, we also published papers on the quality of life, the awareness of the disease, all of which improved. And therefore we found that this project Diabetes with Dignity interventions were quite effective in reducing A1C, and that capacity building of community health workers is important. This project could not have taken place because without the help of Dr. Srinath Reddy and Dr. Nikhil Tandon from the All India Institute and the Kalra Diabetes Institute's Diabetes with Dignity team, and of course other people who participated. So friends, I've talked about diabetes management of India. There are problems everywhere. And through our experience in community, we try to design a new way forward. At present, this project is handed over to the Maharashtra government with all the documents, all the community health worker training manuals, everything, so that they are now taking this project forward. They've added diabetes to the list of diseases covered by the accredited social health workers. So this is to tell you all the partners participating in it: the Public Health Foundation of India, the Kalra Diabetes Institute, my colleagues, the Arogya Bhavan, the Zilla Parishad, and other stakeholders. This is a paper I published in the Indian Journal of Endocrinology and Metabolism, where I talked about the importance of a dualistic approach to manage type 2 diabetes. So we look at the overall numbers of type 2 diabetes in India. We say, okay, there are more than 77 million people with diabetes in India. Their HbA1c is 8.9, and those are stark numbers. But we also need to look at it not from the stark numerical point of view, but from the day-to-day patient point of view also, the individual patient sitting in front of you. And there, you cannot, therefore, take individual goal-based clinical trials and these large multi-center trial. You can't take the p-value of an empagliflozin trial and apply it to a population, because you are not going to be able to control what is called the social determinants of health, which we used to read about in our MBBS books, which talks about the availability, accessibility, affordability, and other socio-cultural factors that impact health. So therefore, we as doctors should not try to take large trials and these big numbers and try to apply them to populations. For every population, whether it's urban, whether it's rural, wherever it is, we should design a delivery which is unique to that particular area. And also we as doctors, often we are comfortable with sitting in our clinic and seeing patients, but I think it's time we ventured out into the community and made the community aware. I'm sure that all of you sitting here are doing it, but I think the whole country can do that, because as India grows, type 2 diabetes is going to increase, and I showed you the obesity prevalence in rural India as well from our studies, and this will mean that more and more efforts are needed from all of us. Once again, it's a pleasure to be back in CMC Vellore, where I was spent 5 very fruitful years of my life. I enjoyed meeting my friends, my teachers, and it's a wonderful feeling to be back home. Thank you so much for listening to me.
He is the Treasurer of International Society of Endocrinology, Vice President, South Asian Society Obesity Forum. Areas of interest: diabetes, person-centered care. Probably many of the publications have been reached in many of the audience. Publication over 1,000 in PubMed Index Journal and high index 68, I-10 index 439. So very fascinating for anybody. And I am very lucky because we are working very closely from Bangladesh. Now floor is open for Dr. Sanjay Kalra.
Thank you, chairpersons, for those kind words, and good evening, friends. So much of praise I have never got. I wish my wife was listening to you. And especially my father-in-law. It took me 1 year to get him to say yes to us, to our match. So in North India, we have this concept. When you go for a wedding, the groom, they read something called the Sehra, which means that they will have a list, and in poetic form, they will talk about the strengths, the achievements of the great-grandfather, the grandfather, the father, and the groom. So that is told to the women's side, to the bride side. So that kind of a thing we read in diabetes as well. We know that we have challenges. Dr. Sylvia has spoken about them. Dr. Unnikrishnan has spoken about them. But we also have strengths. And both Dr. Sylvia and Dr. Unnikrishnan have spoken about strengths as well. This concept of diabetes with dignity is important. Now, dignity is such a simple word, so simple, but look at the weight that it carries. How many letters in the word dignity, Dr. Unni? 7, yeah, quite good at maths, okay. So just 7 letters, but they carry a lot of weight. If we can bring that dignity, first of all, into our thought process, into our speech, into our interaction with the patient, and then what Dr. Unni said, not only with the patient, but with the community at large. If we can do that, automatically so much will be achieved. But my topic for today is person-centered care, and it builds up beautifully upon what Dr. Bahendeka and Dr. Unni have taught us. So let me go on with the topic. But I cannot resist asking a quiz question. So how many students of CMC Vellore are here? Students, okay. So this quiz question is based upon what Dr. Unni said. He talked about different trials. My question is, which is the only kind of randomized controlled trial in human beings where an informed consent is not required? If you want to put your hands down, you are welcome. Now the question goes to the faculty of CMC, Vellore. So which is the only RCT? And Dr. Unni knows the answer, so he's smiling. Question can be answered by Jipmer Pondicherry as well. So we'll answer this at the end. Which is the only RCT where you do not need to take an informed consent? And the answer was given by Dr. Unni in his talk. Might be excused for thinking that person-centered care is a new concept. It was invented in 2024 by the Endocrine Society of USA. But that's not right, because for the past many years, ADA and ESD have also been saying the same. They use the word patient-centric. In general, the correct word is person-centric or person-centered care, because the patient is a patient only for the few minutes that he or she is in our clinic. The rest of the time, that person is an individual, a mother, a father, a child, a sibling, a spouse, and a part of community, like Dr. Unni said. So social determinants of health weigh in on that person. It's just for the few minutes in the OPD that the person is a patient. So like we said, you could have been excused for thinking that person-centered care was invented in 2024, but that's not right. ADA, ESD have been saying that for the past many years. And actually, Indian guidelines on psychosocial management of diabetes antedate all the Western guidelines in diabetes. In fact, at that time, national guidelines were created, and then we realized that different parts of our country have different requirements. So we also had ethnocentric guidelines for Northeast India. And this was at a time when WhatsApp, Twitter, Internet were not there or were very weak. And it took a lot of time to get all those 7 sister states together to agree upon a consensus. And even this is not true. It's not that person-centered care was invented in 2011 or 2012 when these guidelines were published. From Ayurveda, we have Atreya's quadruple. So what Atreya said was that you are sitting on a chair, each and every leg of the chair has to be equally long, equally strong. I'm sitting here at a podium, I'm standing at a podium, each and every leg of the podium has to be equally strong. Only then will I achieve stability and success. So what Atreya said was that 4 aspects, 4 stakeholders have to be equally competent if you want to achieve successful therapeutic outcomes. The person living with disease, the physician whom that person chooses, the drug which that physician chooses or the intervention, and the attendants, that is the caregivers or the family members. So person, physician, peers and family members, and also the pharmaceutical preparations. We converted this into a quincunx. Quincunx means a quadruple with a dot at the center. And at the center is the person living with diabetes, surrounded by physicians, the healthcare team as well. So see how Dr. Unni so beautifully brought out, you get a lay person into the team and quality improves. That person will remind you that you have to look at LDL, you have to look at blood pressure, you have to look at weight. And of course the drugs or other interventions and the caregivers. We revised this and we put family and society also. So look at this now, the person living with diabetes surrounded by family, society, again the community, social determinants of health, also part of a healthcare system, good or bad, strong or weak, the quality of the healthcare system and the way we converse with the patient, that influences diabetes outcomes. If I'm rude, if I'm judgmental, if I'm sarcastic, the patient will not come back to me again. The patient will go to alternative care. The patient will go to faith healing, traditional healing. And then we will sit back and criticize and crib, and we will say that our patients are not educated, the community is not educated. While actually the fault is ours. We were not polite, we were not friendly, we were not affable, we were not empathic with the patient. There are also rules and regulations that we have to follow. So who can prescribe a particular insulin? Who can prescribe a particular GLP-1 RA? These rules should be followed by our colleagues in pharma and by our colleagues in medicine. Putting all this together now, we come to the definition of person-centered care. This is from Washington Institute of Medicine. And they say you provide care that is respectful of and responsive to. You respect and you respond to the person in front of you. And you ensure that the individual patient's preferences, needs and values, 3 things. What does the person prefer? What does the person need? And what does the person value? All this guides clinical decisions. The person values that she wants to keep a fast for Sabbath. Can you help the person navigate that? Another person says, I want to keep the Ramzan fast. Can you help in that? You may or may not be able to, but at least you should respect the person's preferences and needs. And you should respond to them. So you should be able to say, yes, 6 weeks from now, 7 weeks from now, Ramzan is approaching. I know that you are concerned. Let us do a risk stratification. Let us see if you can fast safely or not. That is the minimum that we should be able to do. How do we redefine this classification or paraphrase it? This is person-centered care in its beauty. And speaking to those from the West, I come from a state of India which is not very well known for its prowess in English. So that is why I get stuck at ABC. We cannot go beyond that in the alphabet. So this is care that is characterized by conscious compassion and compathy. An example of compassion and compathy, Ida Scudder. You don't need to go anywhere else. But I am a CMC Ludhiana alumni. And I know that suddenly that doesn't sound very nice in CMC Vellore. But Dame Edith Brown, she was also a paragon of conscious compassion and compathy. Dame Edith Brown is the founder of CMC Ludhiana. And her motto was, my work is for a king. Who is the king? The king can be Jesus. It can be a higher authority. But for Dame Edith Brown, the person walking into her clinic, that was king. At that point of time, when you are in the clinic or in the ward or in the OT with a patient, that patient is your king. So you will serve the patient the same way that you would serve a higher authority. So compassion and compathy for that king, catching that person's complaints, concerns, and challenges. So not only the complaints or symptoms, but also the concerns and challenges. If I take insulin, my husband may divorce me. That is the unspoken thing. You have to be able to feel it from the patient. And you keep all this at the center of all your conversation, all your clinical planning. So you should be able to converse in words, but that conversation should also catch that non-verbal cues from the patient. So those cues you should catch. Now suddenly you feel all this in a 5-minute OPD, how can I do it? But you keep on trying, you just be a human being, you be humane, and you will keep on improving. And at the same time, you should be cognizant of the individual's convenience, comfort, and cost-related issues. This is not to say that we abdicate responsibility. If a person comes and says that I have DKA, but I want to take oral medication, we are not going to let the patient take oral drugs. We will counsel the patient. We will explain to the patient in simple ways. We will share information, share decision, and get the patient to agree to insulin. So this is called responsible person-centered care. There are indices also to test for person-centered care. So like Dr. Unni said, they did research and they found out about quality of life. You can actually use a person-centered care index for your clinic, for your department, for your hospital. And in this index of person-centered care, it's not just the person and the provider, it's not just two of us together. It's also about ethics. It's about holistic management. Individualized care while being cognizant of culture and society. All these things coming together to create a person-centered healthcare delivery. We've spoken of definitions and descriptions, so now you have a fair idea of person-centered care. Yeah, these are things that are part of us. We never thought that they are important. But now come to think of it, I did make a mistake yesterday. I was rude to one patient. I wasn't rude verbally, but from inside me, I looked down upon that patient. This patient is illiterate. What does she know about diabetes? If I could revisit those 5 minutes, I would change myself. So do we have options? Do we have opportunities? How do we crystallize all this into something tangible in our OPD? The first thing is to begin speaking about it the way we are doing now. Involve your patients in decision making. Would you like to take tablet twice a day or once a day? We have 2 options. We have options of 4 injections, 3. What do you like? Biomedically, I think 4 injections is better, but what are the challenges that you face? Let's talk about them. So begin integrating them. When you hold CMEs, call people living with diabetes or disease. And always continue to introspect and improve. When we speak, for example, in the OPD about Mediterranean diet, you can also speak about a traditional Indian Ocean diet, which would be healthy food coming from Uganda, Kenya, or from Bangladesh or India. And healthy ways, protein-rich ways of cooking idli and dosa, pesarattu, this is what we explain to the patient. Comfort foods and beverages. You told the patient to take 2 tablets 4 times a day. Patient complains of weakness. Do you necessarily have to give a multivitamin? In Haryana, the comfort beverage would be turmeric milk. So what would be your favorite comfort beverage? Any student? Dr. Unni, your favorite comfort beverage? Lassi, buttermilk. So whatever is appropriate for the patient. Again, doesn't mean that somebody with hyperkalemia, you tell them to drink coconut water or you tell them to drink lemon water. Be aware of the biology, the biochemistry, but introduce these comfort beverages and spices. So on one hand, you have a doctor who says 4 tablets and 4 injections a day. On the other hand, you have a doctor who says 4 injections, 4 tablets, and a glass of milk with double cardamom, with double spice. Which doctor is better? So you be cognizant of culture and you help your patients accordingly. So we've talked of traditional diet, we've talked of comfort foods and beverages. Another aspect of person-centered care would be psychological first aid. The same way all of us are trained in delivering first aid in case of a road traffic accident, when the person coming with chronic disease, living with chronic disease comes to you, offer psychological first aid. That means you understand the psyche of the patient and you offer assistance to prevent psychological health from worsening and to promote recovery. Everyone does not need the care of a mental health professional, but everyone does need psychological first aid. So whether you use laughter yoga or mindfulness, or you tell the patient says, I cannot go to the gym, so why don't you try some traditional dance like the Bhangra? Whatever you do, you should be able to offer this to the patient. And 90% of the patients will be happy with your first aid. They will not need to go to a mental health professional. The same way we speak about lifestyle, we should also speak about mind style. Not mindset, but mindset is, it's stuck. It's not moving. It means you cannot change. Mind style is fluid. It's dynamic. So let's work on our mind style. Let's make ourselves more healthy from inside. So many options and opportunities now coming up. But again, if I were sitting in the audience, I would be more confused. Till 20 minutes ago, I was very happy with life. I was the best diabetologist, the best endocrinologist in my city. Now suddenly I realize I'm being punctured and, my ego is being punctured and being hurt from multiple points. So many mistakes, so many issues. And the challenge that I'm facing is, how do I do all this in 3 or 4 minutes? The biochemistry, the biomedical part itself is so tough. How do I introduce all this? You can do it very easily. It just takes a few seconds. You just integrate this. So, like I said, in English, I cannot go beyond C. In arithmetic also, I cannot go beyond 1. That is why for dignity, we had to ask Dr. Unni and he said 7 words. So 3 typings to do in your OPD. First of all, the sapio type. Sapio means brain, intelligence, like Homo sapiens. And another quiz question for the faculty now this time is, Homo sapiens versus Homo sapiens sapiens. What is the difference and why is the difference there? Open only to CMC Vellore, so Dr. Unni can afford to smile. Yeah. But sapio type means some people are intelligent and they know that they are intelligent. Others are intelligent but they don't know that they are intelligent. You begin teaching them, they will pick up so fast. And then there are others who are just not willing to learn. They are not intelligent and they are not going to move. So based upon the patient who comes to you and the sapio typing that you do, you might want to give a basal bolus insulin with carbohydrate counting. Or you might just want to say 1 fixed dose of basal insulin. Please take 15 units every night. Go back home, come back after 2 weeks. Because beyond that, the patient is not going to learn. So depending upon the sapio type, you choose the complexity, the aggressiveness of your regimen. The second typing is the psyche typing, the psychology of the patient. Some people are angry, argumentative, aggressive. You just try to calm them down. Don't show off your information, your knowledge about diabetes. Just do the basic, calm them down. Offer psychological first aid, leave everything for the next week. There are others who will be apathic, adynamic, very lazy, not willing to move, fatalistic. I am going to die because of diabetes. I am going to die because of sins that I incurred in my past life. These people also need psychological first aid. You need to cheer them up. Then there will be others who will be agreeable, affable, accepting. So then you do the best possible. But for the other two also, the best possible that you're doing is psychological first aid. There will be some patients, first you will have to focus on insulin distress. Only then can you start insulin. It is sequential. There will be others, simultaneously, you will focus on insulin distress and you will start insulin. And then there will be others, like the affable and accepting type. There's no need for psychological support, you just start the therapy. But this is just two so far. Sapiotyping, psyche typing. The third is phenotyping. And this again I would like to build upon what Dr. Meredith spoke about just now. Types of diabetes. So there will be some who are maladaptive anabolic, obese, overweight, metabolic syndrome. There will be yet others who are eubolic. The glucose is disturbed, but the rest of the metabolism is normal. And then there are some who are catabolic. So for those of us who practice in Asia and in Africa, we should be able to differentiate between a lean, healthy individual and a thin, malnourished individual. We should be able to pick up not only protein, energy, malnutrition, but also hidden hunger. Hidden hunger means micronutrient malnutrition. So by looking at the hair, the skin, the nails, you can pick up micronutrient deficiency, vitamin, mineral, and electrolyte deficiency. For those who are malnourished, it would not make any sense to follow the guidelines. Do not give metformin also. That is also a calorie restriction mimetic. Already your patient is calorie restricted. What will you gain by restricting more? And the SGLT2 inhibitors and GLP-1RA are a short recipe for disaster in such a patient. Give insulin. On the other hand, if you have a person who is maladaptive anabolic, then you follow the American guidelines. So 3 things to do in the OPD, and it does not take more than 30 seconds. Sapiotyping, psyche typing, and phenotyping. Phenotyping will tell you the kind of biomedical or the pharmacological approach that you want to follow, and psyche typing and sapiotyping will tell you the intensity or the aggression with which you will do this. How do I do a planning in my OPD? I just follow this. Those who are maladaptive anabolic, I follow the Western guidelines. That is 60% of my OPD. 30% are eubolic, normal weight. We follow normal Indian guidelines. You can use DPP-4 inhibitors, AGI is metformin. 10% is catabolic. Even in a rich state like Haryana, we have a lot of malnutrition, we have a lot of malnutrition-related diabetes. This will come from the weakest social strata. So if I have a lean and thin person with blonde hair, blue-colored eyes, fair complexion, fair for that person's ethnicity or race, stigmata of autoimmune disease, like maybe a thyromegaly, maybe arthralgia arthritis, a malar rash, vitiligo, then I will think of autoimmune diabetes, LADA in adults. On the other hand, if I have a lean and thin person with stigmata of hidden hunger, dark complexioned for that person's ethnic group, complaining of abdominal pain with or without sequelae of pancreatitis, then I will think of MRDM. And then this is that catabolic state, we will prefer insulin. To put all this, just a few slides more, we coined the word glucophenotype, which is the clinical and biochemical attributes related to glucose status, which help us in planning therapy. But glucophenotype seemed very dry, very biochemical to me. So then we came up with the term glycemic personality. When I use the word glycemic personality, now suddenly the person in front of me becomes a person. He or she has a personality. And personality is decided in a very short way by SURE. 2 action-oriented domains. The severity and style of hyperglycemia, the utility and urgency of control. These will tell me how action-oriented to be. 2 caution-related domains. The risk of hypoglycemia and iatrogenic complications. I'll go slow. The enthusiasm and education, that is the sapiotype, the psyche type of the person and the family, the community, that will also tell me what speed to pick up. If I can integrate this SURE concept and the 3 typing, sapiotyping, psyche typing, and phenotyping in my thought process, automatically I become a person-centered doctor, a person-centered physician. My language has also changed over the past couple of decades. Now people come and talk to us about diabetes reversal. So earlier I used to say, no, it's not possible. Now I say, yeah, it is possible, provided that you have the following A, B, C, D, E. So this is my tone now, especially for younger patients who come. For those who have had diabetes for just 6 months or 1 year, they have come to me. I say, thank you for having come so early. Thank you so much, because we have the possibility of reversal. Provided that your age is less, you are a young adult, your BMI is more, and you are willing to bring it down, your C-peptide is optimal, you don't have to check C-peptide, basically pancreatic reserve is normal, and D for duration of diabetes is short. So ABCD, age, body weight, C-peptide, and duration of diabetes. These are given by God, but you have E for energy enthusiasm, E for engagement with us, E for education. If we are able to put this together, there is a good chance of remission, and you can use you can use pharmacotherapy, which is remission facilitating, like SGLT2 inhibitors and GLP-1 RA and metformin. If you are able to do this, and along with that, you are able to motivate your patient, work together as a team, then you will automatically become person-centered. Like Dr. Unni said, we should also be community-centered, and we should look at, and Dr. Silver said, don't look at just the patient, the family, the community, look at the country as a whole. If we all work together, if we all think the same way, if we all speak the same language, I am very sure we'll have a happier and a healthier world to live in. Thank you.
Thank you for the brilliant presentation. A question will be taken at the end of the all topics.
There were questions for the audience also, sir. So one is that RCT. It's a cluster RCT. So Dr. Unni described a cluster RCT. Some villages given to intervention, some villages no intervention. So what the guideline says, as long as there is less than minimal risk to the participants, you do not need to take informed consent. So Dr. Unni did not go to the village and take informed consent from them. That is the only RCT, cluster RCT, where informed consent is not required. And if there was any other question, I forgot, but there was one naughty question for the... Unni, what was that question which we said that you don't need to answer and the CMC people will answer? Yeah, go ahead, please. So earlier we were Homo sapiens. That means that Homo species which is intelligent. But now we call ourselves Homo sapiens sapiens, which means that species which is intelligent and which knows that it is intelligent. So we know that we are intelligent. Because the previous definition of intelligence was, can I use a tool or not? So they used to think that animals cannot use tools. But monkeys, elephants, they are able to fashion tools and use them. Dr. Shadri, sir.
Dr. Unni, very nice presentation. In fact, I was doing a similar kind of thing for about 10 years in a rural community. I'd like to share what we did. What we did was we chose family care volunteers for every 50 families. So you're not dependent upon somebody else. So you train these people up, and they can be just 10th standard, 12th standard pass. They can be taught how to monitor blood sugar, check blood pressure. We provide them the equipment. And we follow them up. Home monitoring is done by them. And our field workers help. We conduct periodic teaching sessions. And we were able to get the HbA1cs down by about 1%. More importantly, foot care advice was able to reduce foot problems and reduce amputation. These are things that can be easily achieved in any community. Only thing is, every secondary level hospital has to adopt a population around it, define it, and say we are going to provide care, and systematize the whole thing. If you do that, you do get outstanding results.
Dr. Azad Khan, sir, from Bangladesh has pioneered involvement of religious leaders in the management of diabetes and GDM. So perhaps, sir, if you could speak about that before we move on.
Yeah, thank you.
Thank you, sir, for comprehensive coverage of patient-centered care and for introducing us to multiple terminologies and different ways of incorporating concepts to the general public. Professor Azad is going to speak on the topic primary prevention of diabetes in Bangladesh. Over to you, sir.
Chairman, please allow me to some who are present almost sleepy. So I will make my talk very short, but I'll point out the message actually. You see, there is only one non-communicable disease for which there is a UN Day, and that is diabetes. And this UN Day for diabetes was sponsored by Bangladesh Diabetic Association and started with a letter from me. But why I am raising this? Because I think most of you haven't read the UN resolution. I don't know how many of you read, but I just want to point out that you can see it has requested the Secretary General to bring the present resolution to the attention of the member states and organization of the United Nations. So it is not only that's tried to highlight that diabetes is a risk for human health as a whole, also there is preventable and all population should take preventable measures, you see. It was first recognized as WHO and IDF and then subsequently, as I said, United Nations. Pandemic is due to mainly type 2 diabetes, but fortunately is largely preventable. That's our talk. These are figures showing presentation, but I'm just raising one issue, that is, if we want to prevent it, we have to understand the cause for it. And diabetes cause you can boil down to two things: hereditary factors and environmental factors. So hereditary factors are practically not modifiable. As you can see, you can compare this growing a coconut tree. The coconut, the seed is the hereditary factor, but it has to be planted and nurtured for the tree to grow. But now I want to bring to you a separate thing, you see. In the same forest or same woodland, a leopard and deer live. The leopard has got a take-off speed of 95 miles, can go up to more than 150 miles. But the deer can go not more than 40 miles, and take-off speed is about 10-15 miles. Then theoretically, all the deer would be eaten by the leopard, but they can't be, because the leopard will tire out in 5 minutes. And the deer can continue for hours, you see. So endurance is an important factor for survival. So it may be the diabetic gene in small doses gives survival advantage when you are hunter-gatherer. So I believe that needs to be researched, but I believe diabetic gene will never be eliminated. The pathway to diabetes is basically the hereditary factor is insulin resistance. What people really inherit is insulin secreting capacity. And when people develop insulin resistance, and if they become, when people have got low insulin secreting capacity, if they develop insulin resistance, then they cannot overcome it. They develop diabetes, you see. I'll skip many slides. So although all the factors for prevention are not known, but we know the lifestyle modification is effective. All the chemo prevention, these are all evidence-based. These are studies that have shown that it has shown, and it is also highly cost-effective, you see. But the question is, do we use the right language and right medium for motivating people? Although it sounds very mundane, I think it's a very important topic. And it's important topic, and the medical community has not given any attention to it, you see. I'll just bring an example. Who amongst you does not know the cigarette is harmful, tobacco is harmful? Everybody knows. Also, I believe some of you, at some stage of your life, have taken a puff. So it is very unpleasant to start with. But still then, cigarette companies are able to recruit people to smoking. You can see how they recruit people, how they motivate people. You can see Ronald Reagan speaking. Amongst here, many people would know the bottom figure, Uttam Kumar, who was the most popular hero ever known in Bengali speaking community, you see. And so this association of romance and smartness And intellectual activity with smoking has been artificially created by the tobacco companies, you see. And we have to mess something with them to be able to. So I was thinking that whether faith-based leaders can do something, you see. So that's my talk actually. So first thing we took that whether we can do something about GDM. I'm sorry for the Bengali writing because the Bengali slogan. You see, the people have tried about GDM, you have heard so much thing about GDM, but we thought, why not start at the time of marriage? Because in our part of the world, children are born, at least officially, through marriage. So if the message is given at the time of marriage, by the marriage register, who are called qazis in our part of the world, then this might do something. So that's what we tried. And this slogan is, all pregnancies should be planned. And this is the preconception clinic, you see. You know, Diabetic Association of Bangladesh has got a huge structure. Our existence is there in every district, several centers, you see. Districts are like counties in Europe. So that's why we started. So I'll go quickly through it. So we put a chart and we train the qazis, the marriage registers, and established pre-conception care center. 56 centers we created, and these are the slogans. As I said, I'll just come to this. The components are registration, counseling the couple at the time of marriage, risk assessment, and then so they should go, before they contemplate pregnancy, they should go to the preconception there, and they will get a complete checkup and advice how to become a healthy pregnant, how to get a healthy pregnancy. And that costs, we put a charge on it. That costs about $4, you see. $4. In our part of the world, people value children, you see. So they are, even poor people are prepared to spend $4 to get healthy baby, you see. And this $4 are distributed amongst the physician, the health center, and project, and also it builds a little bit of project fund, you see. I'll go through it. You see, these are the steps. I'll just then subsequently come this training this. And we did baseline survey on what was the knowledge this, and these are all many published articles. I'll not go through. I'll come straight to the finding, you see. That we found this project is not yet over, but now midterm evaluation has shown that these advice are followed by more than 75% of the couple. And the number of pregnancies that has produced, it shows that there has been a big reduction, you see. And we achieved another very important thing, that we are able to persuade the government that the government has made it compulsory where preconception advice is given, that they carry they have got the preconception advice, which would be given a proper seal recorded on their marriage certificate. The marriage certificate are called kabin, you see, in that part of the world. So this is one thing. This project was discussed even in the United Nations meeting as an innovative project. So guideline, I'll just go through it. This you can see the result. The control, in control they had 35.6% GDM, and in intervention area it was only 17.4%. So very big differences. Although, as I said, it is halfway through the study. The next project I am coming to is that if the message is given during Friday sermon, the Muslims go to prayer on Friday, and there the Imam, who is leading the prayer, gives a sermon, which is called khutbah. So we hired religious experts to frame a khutbah. And in Muslim religion, because the Muslim religion, of all the organized religion, Muslim religion came very recently in that language. So there is a strong message in the religion for good health maintenance. Like message is that if a person eats to full stomach, his prayer may not be accepted. Very, very strong message. So we thought that would be a good thing to do. So we trained the Qazi Imams. As I said, I will be very short so that there will be, if people are interested, they can put a question. So these are training of Qazi. I will just go through it. Also, what we did, because in Bengal, in West Bangladesh, the women do not go to the mosques. So we hired the Qazi's family, Qazi's wife and his, if he has daughter, them, to spread the message among the ladies. You see. So this fatwa that we made, we needed permission from the government. You see. Also, it sounds very simple, but if the Qazis, they have association. They are good political body also. So we were able to convince the Qazi Association, got permission from the government. So we made the fatwa by religious experts, then sent it to Al-Azhar University in Cairo, whose fatwa is taken somewhat official in the Islamic world. Then we sent it to the Grand Mufti of Kaaba to authenticate it, so make it believable, you see. So that's how it proceeded. And then I'll come to the straight to this. There are many, you see. And this fatwa has now been circulated to many Islamic countries. These are the countries that has been circulated. And we opened diabetes care centers in the mosque. You see the mosque in India also, the mosque would be full on Fridays. The rest of the mosques are more than half empty. So we opened diabetes corner in mosque and trained the Qazi, not only to spread the message, but also give primary care, primary advice. So I shall not again go through the detail. I'll come straight to the, and also this project also we made self-sustaining, because for this advice, Qazis can charge a little bit of money. So that gave them a decent earning. I think that's an important thing. The Islamic religion, the Imam is not allowed to charge any salary, because to be an Imam, it cannot be in the actual truly Islamic religion, cannot be a salaried position. You see, a position. So that gives a decent earning also. But mind it, at the present time, the Imams are paid, you see, paid in a different, under a different name. So anyhow, I'll come. So it became a self-sustaining project, and the results are ready now. I'll come straight to the result. Let's see. We also talked to other priests. You see, we talked to the priests in Sanatan religion, Hindu religion, also the Ramakrishna Mission Temple, also the Buddhist religion, and the churches. And they have all agreed to do the project, you see, which is under this. So I will not go through the debate, but I'll come straight to this, because we did this first in 100 mosques and found a big effect, but this was a control study. Subsequently, we did this as a control study, 100 intervention and 100 non-intervention. I'll come. And you can see the result. You see, risk reduction in the control group, 17.1%, you see, incidence for that in year. And in the intervention group, it is 9.8%. 8%. Risk reduction of 42.7, you see, 7. And it has, there are details, I will not go through the details. There are, in every aspect, you see, it has reduced hypertension, it has reduced obesity, it has increased their exercise period. So that means the reports are followed, you see. I shall not go. You can see even physical activity, the control group, you can see the blue, and the intervention group is yellow, you see. It can see big effect. So I would like to conclude that prevention of diabetes is feasible. But it's important to find the right language. and right medium. But I'm sorry to say, this is a subject which is very, very important for people who are dealing with public health. But sorry to say, we haven't done any research on that. We have not done, we only say that we are advising people, they don't listen. But that's not true. The truth is, we have not advised them in the right language. So that's my content. So the summary is that we have to find the right language. I'll not go through it, please. And also, to do this, you see, hardly any financial involvement. We can do this. In Bangladesh, we have done it in now about 200 mosques, and we are now trying to upscale it to do it throughout the country. Thank you.
Good evening, and thank you very much for having me. It's a great honor, and thank you all for being here this late in the evening. So I'm going to talk about the current challenges and ongoing initiatives around improving diabetes care in humanitarian settings. I'm going to talk first about some background, then provide the current challenges. So the first half of the talk will be very depressing, unfortunately, and at the end talk about the importance of collective impact and ongoing initiatives. So at present, we're witnessing record high levels of forced displacement globally, with over 120 million people forcibly displaced worldwide. You'll see the green bars, those are internally displaced people, or IDPs, which means people that are displaced within their country of origin. The blue right above it, those are refugees, meaning people that are forcibly displaced that have crossed an international line and are no longer in their country. So most displaced people are IDPs. Almost 80% of people affected live in lower and middle income countries. And over half of the these situations are protracted, meaning humanitarian crises are taking decades sometimes. People are no longer going home quickly, so most crises take a long time. And humanitarian providers are having to provide long-term primary care. Now, on top of those statistics I just showed you, there are an additional about 200 million people that are affected by natural disasters on average every year. And it is expected that by 2050, there could be 1.2 billion people displaced due to climate change and natural disasters. And you'll see here the map. The orange are the people that are forcibly displaced due to conflict and violence. This was from 2023. And in blue, due to natural disasters. Now, if you look at these maps on the left, the areas of the world that are hardest hit by humanitarian crises, and on the right, the areas of the world where we're expected to have the highest increases of people living with diabetes over the coming decades, they almost overlap identically. So current challenges in the humanitarian arena. So in an acute emergency, if the tsunami hits or the war breaks out, in the immediate phase after onset of a crisis, of course, you're gonna want urgent and targeted assistance to address the most immediate causes of mortality. For example, type 1 diabetes. They require immediate access, ongoing continuity to insulin. This, of course, requires identifying those individuals. We need to know where they are. And typically, the needs assessment is done using the MIRA, the Multi-Sector Initial Rapid Assessment. That is launched, is a coordinated response through a humanitarian coordination mechanism where multiple organizations do a data collection in the field. And based on that data collection, then okay, these are the needs in this particular area. These are the funds we need to raise for this particular crisis, and it dictates the humanitarian response. Now, the MIRA generally does not include NCD-related indicators or diabetes statistics. So diabetes is falling through the cracks in this very early stage. And then, based on the MIRA, this minimum initial service package is launched, depending on what the findings are. So minimum services are launched, but there are currently no minimum initial services for diabetes. One of the major challenges is that baseline diabetes data are often lacking in many lower resource settings. Diabetes is often undiagnosed, and there are no uniform or standardized indicators or data collection systems across organizations. On the right, you'll see the UN High Commissioner for Refugee, their NCD consultations across different countries where they're working. They're very low numbers of NCDs, and that's not because they don't exist. It's because they're not collecting the information, so the data's not there. And as mentioned, there are no predefined minimum standards or services, and that includes insulin. So even insulin is not routinely provided in a humanitarian response, which of course is, unbelievably tragic for people with type 1 diabetes. Now, because of this lack of data, at least in the published literature at the time, we wanted to see, well, what are humanitarian organizations collecting internally that might not be published? So we convened the United Research Consortium consisting of these 7 humanitarian organizations. The idea was to have a first phase, a United 1 trial, where we look at current practice, current data collection systems, and what's happening currently in the field, with then a phase 2 where we develop and field test indicators that would be implemented across organizations. So in the United 1 study, 4 of the 7 organizations contributed to the data collection, and it was a cross-sectional survey. We did this in 2018. Looking at 83 sites globally that were randomly selected, stratified by global region. And of those 83 sites, 78% reported collecting some sort of diabetes data. The sites were across 27 countries and 5 global regions, as you'll see here. The vast majority in the Eastern Mediterranean and African regions. Most sites were refugee camps or rural non-camp sites, and the populations were mostly a mix of refugee, IDP, and the general population. I think it's also very important to recognize humanitarian providers not only provide care for IDPs and refugees, but also often for the local population. And most of the sites were in protracted conflict. Now, the type of data being collected was challenging because even within an organization, so you had like MSF or the Red Cross, depending on what site we were talking about, they were collecting different data in different ways, electronic versus Excel versus paper charts. So even within an organization, there was no consistency. Less than half of the sites reported type 1 versus or insulin requiring, non-insulin requiring people with diabetes. It was kind of a lump statistic, and complications were rarely reported. Surprisingly, a third of the sites did not provide any insulin at all. And here you'll see the IDP camps, again, IDPs being the majority of displaced people globally. Only 14% of those sites provided insulin. Most of the insulin was human insulin in a vial and syringe. In general, insulin availability, we know, is a big challenge in many countries. It is often unavailable in the public sector in lower and middle income countries. In the humanitarian setting, insulin is often reserved for inpatient use only. So it will not be provided for home use. So, you'll hear of stories, patient comes in with DKA, they're treated with insulin, send them home without insulin, they come back in coma a couple of days later, and the cycle goes on and on. And so when insulin is provided for ambulatory care, it's often only dispensed at the hospital level, not at the primary care or more local level. And in a conflict situation, traveling to the hospital, it's very dangerous. And so you'll hear about families moving to right around the hospital so that their kids can go to the hospital multiple times a day for their insulin injections. One of the reasons for this, the reluctance of humanitarian providers to give insulin to these people to take home, is the storage challenge. Most of these settings don't have refrigeration, and of course the temperatures are often high, and so where are you going to store the insulin, if you can't follow the manufacturer's recommendations? Now, in an acute emergency, the WHO has an NCD emergency health kit, and basically these emergency health kits There, you'll see on the bottom these kits, they provide basic medical services for a population of 10,000 people for 3 months. So if a crisis occurs in your country and you need help, you can order however many of these kits. Up until recently, there was no NCD kit, but a few years ago, they did develop one with a cold chain, and it includes some human insulins, glibenclamide, metformin here, as you can see. The problem is there's no instructions on how to use these insulins. People might be on different insulins, and they're often delayed. So you'll hear about a year delay. You know, you order these for the acute phase of an emergency, but the lag time is currently still much too long, and they're working on reducing that lag time. I won't talk about this much, but insulin affordability, huge challenge globally in, I think, most countries. I think India, you have a unique system here, but in many countries it's unaffordable. And the newer analog insulins, substantially higher priced, and pen devices, very expensive. So most of the time, people are getting insulin in a vial and a syringe. Diagnostics, also a very big gap, huge. I would say it's underestimated, I think, how much of an issue this is. Glucose test strips are often more expensive than the insulin itself. You'll see here on the right that these are bar graphs in different countries, the percent cost to a patient with diabetes in terms of supplies. The blue on the bottom is the insulin itself. The red is the meter and strips. So you'll see the meters and strips are the highest cost to the patient. In our United study, we saw that only 70% of the humanitarian sites even had capillary glucose sticks. So 30% did not even have glucose monitoring, and A1C was only available at 19% of sites. In terms of clinical management, many lower middle income countries have insufficient numbers of healthcare workers at baseline. This is, of course, only exacerbated in a crisis. Many people leave the area, understandably. And in many countries, insulin management is often done by specialists, not by primary care providers. So the staff on the ground, primary care staff, have limited baseline knowledge about how to manage diabetes. And there's a lack of adapted guidelines to these very, very fragile settings. I just briefly want to mention also the way that people with diabetes present in these settings. We've talked a lot about this at this conference. It might be different. So this is the Democratic Republic of Congo. MSF is Médecins Sans Frontières, or Doctors Without Borders. They looked at their diabetes program. They had 243 patients, median age is 45. The mean BMI there was 21 in that cohort, and 31% was underweight. And they did a clinical phenotyping of that cohort and categorized 26% of those individuals as having type 1 diabetes, 51 as type 2 diabetes, and 23% they couldn't quite categorize had an indeterminate form of diabetes. They hypothesized potentially malnutrition modulated diabetes. So, you know, these numbers from the statistics we hear globally, the percent of type 1 is extremely high here, and what exactly are they seeing here, we don't know. Of course, in a humanitarian crisis, you need to adapt the service design based on the country, right? A crisis in Ukraine is going to be very different from Gaza compared to Sudan. So you have to adapt the service design to the context. Most displaced populations live in urban settings, but they're not routinely integrated and included in the national health system. So it's a great challenge for them to access care. And of course, there's a high comorbidity of mental health disorders and psychosocial challenges, as I'm sure we can all very well imagine. On top of it, the insecurity of the situation makes things very, very challenging. Many settings have chronic low levels of conflict and instability, where for a while it's kind of calm and then the war will erupt again. So, for example, MSF, or the humanitarian provider, they will provide care but then have to scale back or leave the country entirely for a while and then come back. And there are increasingly, unfortunately, direct attacks on humanitarian health workers and facilities. We've seen this time and time again in Ukraine and different areas where healthcare providers are targeted. So the model of care has to evolve and be very fluid. And finally, NCDs are probably one of the most underfunded issues in global health, I would argue. This graph on the right shows you the percent foreign aid over years towards different kind of medical areas. On the very bottom, the kind of dark green, that's infectious diseases. Then above that is newborn and child health. And then that really tiny baby strip of orange on the top that you see, that is the total financing for NCDs as a whole. That includes cardiovascular disease, cancer, and diabetes, all of it. And you'll see there's been zero change, really, no meaningful growth or change over the past, this would be 20 years. So it's you know, it's unbelievable. Now, this is an overwhelming challenge. It's depressing just to talk about it. It feels overwhelming. It's a huge issue. No, any one organization can solve this problem. We have to work together. Different sectors, right? You need the lawyers, the policymakers, the economists, you need the doctors, the nurses, the healthcare workers. You need all sectors engaged. And so because of this, in 2019, we had a meeting on this at Harvard, basically bringing together over 100 individuals from different organizations just to say, you know, okay, where do we even begin, and how can we work together to address this extraordinarily complicated challenge? And we published the so-called Boston Declaration, which essentially says not providing an essential drug like insulin in a crisis is a human rights violation, you could argue, because for someone with type 1 diabetes, insulin is as important as water or food or hygiene. And also providing an effective diabetes program provides a strong platform, you could argue, for providing high quality care to other NCDs. And so we published this declaration that outlined 4 key targets that the group wants to achieve over the coming years. 1 was unified and strengthened advocacy. 2, universal access to insulin, other essential medicines and diagnostics. The 3rd, establishing a unified set of clinical and operational guidelines. And 4th, improved data and surveillance. Now, in order to make sure that this work progresses and we continue to work together, we founded the International Alliance for Diabetes Action, or IATA for short, which is essentially a collective impact initiative, which brings together over 140 organizations globally with the mission to improve access to high-quality diabetes care for people living in humanitarian crises. And we have 5 working streams. The first is around leadership and collaboration, fostering collaboration community. And then these 4 work streams on the right that you'll see, service delivery, medicines and diagnostics, data, research, financing, and policy, are along the lines of the Boston Declaration targets. And we have different individuals leading those different working groups and multiple organizations doing various projects within those working streams to address the challenges. Here's an image of the various organizations that have been involved. In the interest, I'll keep this very brief just to give you a sense for what we're doing. In the service delivery pillar, working with the WHO on adapted guidelines for acute humanitarian emergencies. We developed insulin switching guides. So for Ukraine, for example, they had 32 insulins on their formulary. Now, if you may not be able to get the same insulin you're used to. So for the provider in the field, all of it, I have a kid on Glargine, now all of a sudden I have to switch to premixed 70/30, what do I do? So these switching guides we helped develop. We're working on a community of learning with some colleagues. We have a nutrition subgroup, which is a whole nother very challenging topic, working on operational guidance with the UN agencies and other humanitarian implementers. In the medicines and diagnostics space, the Foundation for Innovative New Diagnostics is working on affordability, working with manufacturers on finding affordable home glucose monitoring, A1C testing, maybe even CGMs, laboratory testing. The Clinton Health Access Initiative is working on bundling of commodities. So if you're providing insulin, you're also providing the needed syringes and maybe a glucometer and strips with it in a bundle, so they don't have to get things at 5 different sites. And a lot of work on insulin thermostability. I'll just highlight this very briefly. MSF did a study at Dagahali refugee camp looking at about 5 different insulins under the fluctuating temperatures in Kenya. So they just left it out on the counter somewhere, and the temperatures fluctuate between 25 and 37 Celsius. And they showed that after 4 weeks, the insulin retained its integrity. So they were able then to provide insulin for home use. So now these individuals could take insulin home, which was a real game changer for them in terms of quality of life. There was another insulin thermostability study here in India, in Nagpur, that Graham Ogle and others led, looking at also a variety of insulins, analog and human, in very hot Indian summer climate. And essentially the bottom line is that after 2 months, all of the samples retained their integrity. And after 4 months, 37 out of 40 samples retained their integrity. So even if you don't have a fridge, don't throw away the insulin. You know, it's still usable in an emergency situation where you don't have other options, and clay pots significantly help maintain the temperature as well. On the data and research front, I already mentioned the United 2 study we're hoping to do. We're working with Kaushik Ramaya here and Bedora Zabin in Bangladesh, doing the Human 1 trial, looking at human versus analog insulins in youth with type 1 diabetes. And on the financing and policy front, the WHO developed their Global Diabetes Compact and launched a World Health Assembly resolution that included diabetes care for humanitarian affected populations. We're working on the policy level, doing technical briefs, preparations for the UN General Assembly later this year. And I'm over time, so I'll keep it brief. But the good news is that the WHO and UNHCR earlier this, or I guess this would have been now last year, hosted the first high-level technical meeting on this challenge on NCDs in humanitarian settings. And I think we need the political will, we need the financial will, we need to work together to improve this care. So these are my conclusions. I'll leave it at that and happy to take questions later. Thank you.
I will start off with the questions. First to Dr. Unnikrishnan. You used the hub and spoke model of mobile clinics in a particular area. You are planning to get it expanded to Maharashtra as such. So, I think ASHA workers are all over the country. So, so I think it can be with the government will. I think it has a capacity to be implemented all across the country. So, is there what limits the any particular factor which limits?
Well, I think what we did, we were able to accelerate the government machinery, and actually we concluded our community project. Now our next project is on some other NCD. So we handed over the materials and now the Maharashtra government is doing it. Now your question is, can this also be expanded to other states? Why not? It should be. Only there are few things preventing it. I think there are national considerations, there are financial considerations. Each state has a different policy, and whether a state wants the ASHA worker to focus on diabetes, or if there is any other pressing need for health in that state. So these may be considerations, but I think looking at diabetes in isolation, I think it's very good to consider at least that other states also adopt similar policies.
Thank you. I think combining what Dr. Unni said with what Dr. Sanjay Kalra said, I think it is important to communicate with the community first and then figure out what their requirements are. I think this is one of the important things that we fail to do. If you have a defined geographic community which you are dealing with in a hospital setting or even a clinic setting, then it's possible to put together a plan. And it's important to involve them in decision making. It's not enough if you say these are our decisions, you follow them. It doesn't work that way. We have to involve them in the decision making. It has to be a combined thing. Even things like diet, I think you really need to find out what their staple dietary items are and then modify it in a way that is acceptable to them. Otherwise, giving them a diet sheet doesn't work. So there are many practical considerations that are there. And we need to look into all this if we want to make a big difference to diabetes in rural India.
I think it's a very important point. In rural India, we can't go and tell the community that we want to diagnose diabetes amongst you, because they might tell you that their problem is lack of rain or lack of fertilizer or lack of crops. So in our mobile clinic program, we've always gone to, in the real world program, we've always gone to the village, asked them, and only if they show an interest, we have taken that village on. Because otherwise, the population which doesn't need it, you're offering something which they don't want, it's not likely to be successful. So that point is very well taken.
That is why getting a family care volunteer elected from a group of families to coordinate with the family is very useful. And that model works very well.
I think that is in many ways better than the community health worker module, because you don't have to actually pay the family worker to take care of it. Whereas the community health workers are incentivized to diagnose a particular disease.
They have a sense of ownership, and so they do a much better job.
Absolutely.
I have one question to Dr. Sanjay Kalra, sir. Sir, myself, Dr. Azad from West Bengal. Sir, you have told about the person-centric diabetes care. So regarding this issue, I just want to ask you that sometimes some patients are not able to take decision or to give any decision to the treating physician regarding and they are not able to discuss about the things. They are dependent to the decision taken from other, like husband or the other family matters. So this is one problem. So how can we overcome this problem? One thing. And another thing, sometimes some patients are in so hurry or their motive to come to the clinic of the treating physician that they will come, take the treatment and they will go out from the clinic. They just don't want to hear anything from the, either they don't have time or they are reluctant to hear from the physician. So how can we overcome or tackle these two issues? Sir, please clarify.
The rule, and both these situations we face in the OPD every day and we face across the world. So look at the definition. Be respectful of whatever they say. Supposing the person says, I am in a hurry, I have to go shopping, I have to collect my my kid from school. Respect that. But be responsive as well. Responsive will be, I understand you are in a hurry today. We should be talking about diet and stress management. Maybe when you come back next time. That is first rule, respect and respond. Second rule is, in endocrinology, we talk about endocrinology means the hormone is being secreted from here, is working far away. This is difficult to understand. You look at paracrine effect. So the adjacent possible. Let us say I look at the patient and I feel she is very shy, she is not speaking in front of her husband or her brother. There might be a menstrual issue. There might be a genitourinary infection. So I will think about adjacent possible means what's the next thing. So in a very quiet tone, I might say, would you want to discuss something with a lady healthcare professional? Then she may say yes. And depending upon who is there in your office, it might be a gynecologist. It might also be just your receptionist. Let her spend a few minutes with the receptionist. So the second is the adjacent possible. Adjacent possible in terms of symptomatology. Adjacent possible in terms of the healthcare provider. Patient doesn't want to talk to me about exposure to sexually transmitted disease. He may talk to my junior doctor about that. Now, having said both these things, sometimes in endocrinology, we are number dependent. So let us say I want to screen entire Bangladesh for subclinical hypothyroidism. My quality is dependent upon the quality of the TSH assay. But if I want to screen for melanoposthitis, pruritus vulvae, or even pain in the joints, it is dependent upon the history taking. History taking is dependent on the way I speak, the way the patient listens, and the ambience. So we should be aware of our limitations as well. I come from a culture where for some patient I might have a very paternal or grandpaternal kind of attitude. So that boy will never come and tell me that he has taken alcohol last night because he will feel that he is going to get scolded. And he will never tell Dr. Azad Khan, sir. But if somebody younger like Dr. Unnikrishnan or somebody younger looking like Dr. Unnikrishnan goes, then he will say, sir, I took alcohol, I took tobacco, and I also did the following 4 things. So this is just the third thing. So first was respect and respond. Second is the adjacent possible in terms of what history you are asking. The adjacent possible in terms of who is asking, who is taking the history. And the third part was be aware of your limitations. Do not say that the patient did not share her information. Maybe I did not elicit the information properly, so you do a better job. Before we move on to the next question, I will talk about how we use the adjacent possible. So, we are criticized by the entire world for medicalizing normal physiology. For example, we are criticized for medicalizing menopause or for medicalizing a glucose of 126 or 200. Now, recently we have these WhatsApps that say that the American College of Physicians says up till 250 glucose is normal. So, if the Americans say that 250 is normal, who are the Bangladeshis and Tanzanians to object? So, these kind of WhatsApps are going on. The answer to that is that actually medical disease is normalized in society. So, in my OPD, it might go like, Madam, how are your joints? Do you find it difficult to go to the temple or to go to the mosque or to go to the Gurdwara Sahib to pray? And the answer is, how do you know? So you say, yeah, I am here, I can help you handle your joints and you're going to give calcium, vitamin D or whatever. But see the bonding that occurs. So you ask about symptoms that are non-threatening and that you feel the patient may have. Even if she doesn't have, her sister will have, her sister-in-law will have, and next week they will come to show you in the clinic. So either it is a win-win for everybody.
Thank you, sir.
Okay, I like to supplement one, just considering these two topics. Sanjay Kalra knows that if you can read the mind of the patient, every problem is solved. The problem is that the patient is in hurry, not that. The physician is in hurried situation. So you are not giving appropriate time, appropriate attention. So if you are very much cool and attentive to the patient will speak out. And patient is patient. He is a diseased person. He will have or she will have many problems, but physician should not have any problem, as he is a service provider. So physician should be able to read the mind of the patient. So probably every problem will be solved. Thank you.
Thank you, sir.
I have a question for Dr. Unnikrishnan and Dr. Alice David. I used to work in the community health department here in CMC Vellore for many years. And we have always done this mobile clinic. Dr. Venkat would know, who would from Dr. Ida Skada's days, right? And what you have done is taken diabetes to primary care, and that is really commendable, and congratulations for achieving that. So my question is on how did you manage foot care for the diabetic in a mobile clinic? I ask because I'm actually an epidemiologist, not a physician, and I come from Believers Medical College in Kerala, and we had recently written up a research grant to include a mobile clinic that included foot care. And our budget was quite big. And I want to know how you managed to do it as cheaply as I assume you did.
Yeah, so I think in the first two mobile clinic programs where we did it, this was funded by all our mobile clinic programs are funded by the Chalaram Foundation, which is part of the hospital and the organization. So I think what we did is initially to check for the pulses, look for deformity and identify the loss of protective sensation, which is the monofilament, which doesn't cost anything. And studies have shown that if you look at just three things, look at the pulse, look at the deformity if present, and just look for LOPS, loss of protective sensation, which means using a Semmes-Wellstein monofilament and just looking whether the patient is able to perceive pressure. This can potentially, this is the most powerful tool to actually prevent amputation, because it gives you a definite answer, yes or no clinically, and it will prevent amputation. In our advanced mobile clinic, which we tried, in that, of course, we had a biotissue meter and a Doppler. Frankly, we didn't find that to be that cost effective when we detected foot problems. We found the other one, the first one, was much more effective in cost effective in terms of that. So if you have a mobile clinic program, simple clinical examination for three things: foot pulses, deformity, and a simple 10-gram monofilament to check. That's more than enough to prevent foot problems. And in addition to that, we also have prepared materials which we can, of course, share with you. We have it in Marathi and in English, where we give it to the patient to tell them about foot and pregnancy-related diabetes. These two things, we specifically give them handouts to read with some pictures and colors, and that's more than enough. I think we'll have to adopt the particular tool we have in terms of the particular, facilities we have, and then tailor the program to that community.
Okay. So my question again, sorry, I have one more question. In Kerala especially, what is, many of them are diabetic, and the foot, they come very late. They do not realize that they have a problem. So, and they don't want it to be amputated. And so are you able to manage people with little more severe cases in the mobile clinic?
No, we cannot manage it in the mobile clinic, because once they have an ulcer or an amputation or a major infection, they have to go to the hospital. So what we have done is that we've worked in collaboration with the sub-center or the primary health center, and we necessarily have the doctors of those centers with us. And fortunately, because Maharashtra is a state where the hospital, the government setup is pretty good, so they are able to get referred there and to take care there. So I think that is very important. I'm sure Kerala also that will be the situation. But mobile clinic, we should not even try to manage any advanced foot problem. In fact, we did publish telepodiatry, a series, and we looked at even telepodiatry, whether that could detect foot problems. And our understanding from that is that anybody with a foot problem, an infection or a suspected infection, needs to visit a hospital, and you cannot depend on mobile clinic. But there is one mobile clinic program by Dr. Suresh in Bangalore at the Mahavir Jain Hospital, which has successfully even looked at treating foot infections through mobile delivery. You can get in touch with their team. I think Miss Vinaya is the podiatrist there who conducted that program. But I think it's very risky in Indian settings.
Okay, thank you very much.
Thank you very much, and I think I'm afraid we are short of time, so we'll conclude the panel discussion. I want to thank all the speakers for the wonderful lectures, and I want to close this session.
Thank you very much for that very kind introduction and conference. And in fact, there's going to be several of the slides you've seen already, so I apologise for the repetition. It's honouring other people's work. So I'm going to talk about global patterns of diabetes. You've seen some information about this already, and with a particular interest in the role of body mass index, measures of leanness and obesity. So what I'm going to cover are the estimates of current and future global diabetes prevalence. We heard some of that from Peter Schwartz earlier. Some are going to describe some of the time trends in key risk factors, things that affect mean that obesity has different effects on the risk of diabetes, and how patterns have changed in terms of obesity over recent years. And I'm going to talk briefly about different sorts of diabetes as well, and how that all fits in with the previous topics that I cover. So we've seen this slide already. There are several estimates of the numbers of people in the world with diabetes. This particular slide is from the International Diabetes Federation Atlas. The NCD risk group have recently come up with estimates that are much higher, as Peter Schwartz said, than the IDF estimates. And I think one of the things I say to all of my students is that all estimates are wrong, and that's why we have to be really careful when we talk about the numbers of people with diabetes, is to make it clear that they are all estimates. So, for example, I'm going to take India as an example. These IDF estimates estimated that there were 74 million people with diabetes in India. So that's of 20 to 79-year-olds. Many of you will be familiar with the INDIAB study. I'm going to mention that later on. That estimated that there are 101 million people with diabetes in India, and the NCD risk estimates are of 200 million people with diabetes. So there's quite a big difference in those estimates, and nobody really knows how many there are, but I think we can safely conclude there are a lot of people with diabetes in India. And this slide, this global slide, shows the relative prevalence in parts of the world. So the dark blue countries, like Saudi Arabia, are the countries with the highest prevalence. And then the really light colours are the countries with the lowest prevalence. And I think one thing you can say about all the global estimates is that this relative prevalence is the same in all of them. Although, interestingly, seems to be a bit of a competition between China and India as the country of those two countries as which has the highest number. Certainly in these latest estimates, India has higher numbers of people with diabetes than China. I'm not sure that's a competition you want to win, though. So the good news, Sylvia split her talk with starting with the bad news first and then the good news. I'm going to have some good news first. And these are some data that a colleague in Australia, Diana Maliano, has put together, where the countries that have got information on death rates in people with diabetes shared them. So we could show on the left-hand side there that death rates for people with diabetes are coming down. So that's good news, obviously. And that's one of the factors that contributes to increasing prevalence. People with diabetes live longer. Don't worry about the information on the right-hand part of the slide. But other than to say that although death rates are coming down in people with diabetes, they're also coming down in people without diabetes. So, as you all know, diabetes does confer a higher relative risk. So people with diabetes die earlier than people without diabetes in all countries. This again was some work that Diana's group put together, and this was describing patterns of incidence, mainly in high-income countries of diabetes, up to 2017. So this was before the pandemic. And it was interesting to see that in many countries, including in the US, that incidence, that's new cases of diabetes, appeared to be declining. Now, when we submitted this paper for publication, there was much discussion from the reviewers about why this might be. And one explanation might be the switch of diagnosis from first of all, a glucose of 7.8 down to 7, which happened in 1998, and then the introduction of HbA1c as a diagnostic test for diabetes, because you pick up fewer people with diabetes if you use HbA1c, even in largely European ancestry countries, but HbA1c certainly picks up fewer people with diabetes in many countries in the world. So that was one explanation. We've also been talking about life course, and Ranjan Yajnik's talk about the very important factors associated with birth weight. Also Alan Vei's work, he presented this slide earlier today, and using it again to reinforce the point about the importance of birth weight and subsequent risk of diabetes. And so in many of the countries listed on that previous slide, we've seen declines in the numbers of low birth weight babies in recent years. And so I just mentioned some data on the right there from UK countries about the proportion of low birth weight babies. So we're seeing perhaps fewer people affected by those challenges during pregnancy and early life. And as you'll all be aware, the worst combination is to be a thin baby and a fat adult. And so if we're seeing fewer of the small babies, maybe you can get away with being a bit of a larger adult if you weren't also a small baby. So this was another possible explanation. However, I'd like to point out, this is some data from Scotland where I'm based, is that we've seen a different pattern after the pandemic, where we've seen incidence of type 2 diabetes going up again. And there's a lot of information on this slide, but the point that I wanted to make here, so the grey bars are the ratios of diabetes incidence compared to 2018. It's gone up in all ages in the grey bars, but it's gone up more in what I describe as young populations, so that's under 40-year-olds. So it's a particular concern that we're now seeing more diabetes in young people because, of course, they've got a longer lifespan to live with diabetes and develop complications. Now, something else that's changing in the world is that the world's population is getting older. So on the left-hand side there, that's data for 2000, where the age distribution really does look like a pyramid. We often call these population pyramids. But what we're seeing, the middle graph is for 2021, round about now, and the right-hand graph is for 2045. You can see the age distribution no longer looks like a pyramid, and the relative proportions of older people increase. And as you're all well aware, age is one of the most important risk factors for diabetes. So the more older people we have in the population, that also contributes to increasing incidence and prevalence of diabetes. And then, of course, what's happening with obesity is increasing in all countries. So this is a slide that's got Indian data at the bottom. So you've still got much lower proportions of obese by international standards, so really obese for Indian populations, which might be one of the reasons why you're at the bottom of the graph there. But as you can see, in all countries, obesity is increasing. And again, that's such an important risk factor for type 2 diabetes. It's no wonder that we're seeing more people with diabetes in the world. There's a group that's tried to look into the future and work out what's going to happen to the prevalence of obesity in India, and this goes up to 2040, and the estimation is that it's going to increase. So again, they used standard global definitions of overweight and obesity. It would be really nice if they'd used the Indian-specific cut points, but they didn't. But generally speaking, there's prediction here that there's going to be increasing obesity both in rural and urban populations. Time will tell how accurate these predictions are, but it's a concern. And then this was a slide just as a reminder, if we needed it, it's a bit of an old one now, that obesity is a really important risk factor for diabetes. And depending on the definition and what age group you look at, it increases risk of diabetes by up to 5 to 10-fold, depending on your comparison group, what you describe as normal. And I said I was going to mention the different effects of obesity on risk of diabetes, and these are data from Scotland, really to show differences in our population about obesity for men and women. And essentially in Scotland, women have to be considerably more overweight than men to develop diabetes. So men get diabetes at a lower level of BMI at all age groups. And again, this really shows the importance of age, because when you're young, you need to be very, very obese before you develop type 2 diabetes. As you get older, age is the most important factor, and obesity only makes a small difference. Now, in that previous slide, I forgot to mention that was limited to people who had a BMI, or body mass index, of over 25 kilograms per metre squared at diagnosis of diabetes. And one of the reasons that was limited to that group of people is these data, that the obesity paradox. So even in Scotland, the dots, you can see this is a J-shaped curve, so that the lowest mortality is in the group who are have a BMI of 25 to 30. And people who develop diabetes and have a BMI of less than 25 have higher mortality than the 25 to 30. And then with increasing BMI, mortality increases. So this suggests that there's something different about the group of people who have a low BMI. Now, one of the explanations that's often given for this is smoking. We know smoking is bad for you, it increases your risk of mortality, but these analyses removed people with, these are just non-smokers, so we still see this pattern in non-smokers. Another thing that affects has an effect on obesity and risk of diabetes is ethnicity. So these are data from the United States comparing people of white origin. One of my mentors, Raj Bhopal, really objected to this term Caucasian because people from North India are also Caucasian. So we shouldn't use Caucasian when we're talking about white Europeans. So I apologize for this slide. And then a couple of other ethnic groups as well, Hawaiians and Japanese. And so the bottom left there's the risk of diabetes in the lean white population. And even if they're lean, the Hawaiians and Japanese had a higher risk of diabetes than the white population. But as BMI increases, the risk for the non-white ethnic groups increased more. And this next slide also gives this information. This was, I thought, was a very clever study done within the UK because they took the risk of diabetes at a BMI of 25 for the white population and then looked at what BMI, you got a similar risk in different ethnic groups. And you can see there, I won't list them all, but for all non-white ethnic groups, the BMI at which the risk of diabetes was the same as the white group at a BMI of less than 25 was low. And you see for South Asian populations, that BMI was as low as 19.2. And as Meredith said, we were discussing, and Nihal said, we were discussing how do we define lean. Well, the original WHO definition of lean or underweight was less than 18.5 kilograms per metre squared. So that's often used as a definition for lean. But as you can see, we should probably have ethnic-specific definitions of lean. And this is a slide from the United States showing how again, how ethnicity is important and how it relates to BMI. And again, I put a box around the Asian group. Now, in the US, they often don't separate out Asian Indians from Chinese origin populations, so they'll be muddled up in this group. But I want you to look at the left of that green box, where really the group with the lowest BMI, what's described as underweight, have very similar risk to the normal weight group. Whereas in most other ethnic groups, the underweight group has a lower risk. So again, suggesting that perhaps there should be further distinctions in that lean definition. So I said I was going to talk about data from INDIAB, and so this was a fantastic study. I have to commend Anjana and colleagues for doing it. So not only did they study representative samples of all states, all mainland states across India, but they did this during the pandemic as well. So to complete this study was a real achievement. You might think a study that took 7 years, that's a long time, but of course India is a huge country, so it's a huge achievement to have completed this study. So, and what this slide shows beautifully is it separates the states by rural, so those are the top bars, the bottom bars are urban areas of the states, and then Not only that, there's socioeconomic status as well. So I'm sorry the text is so small, but the pink bars are low socioeconomic status and the blue bars are high socioeconomic status. And so there's a really mixed pattern in India, depending on which state you look at, whether you're in a rural or an urban area, and whether you're of a low socioeconomic status or a high socioeconomic status. So perhaps some of you would have been able to guess these findings, but the highest diabetes prevalence was in low SES urban residents of Chandigarh, where the diabetes prevalence was 27%, more than 1 in 4 people. And then at the other end of the scale, low socioeconomic status, rural inhabitants of Meghalaya, I hope I pronounced that correctly, where the prevalence was only 1%. So a complete spectrum showing, I think, following on nicely from the previous talk about the diversity in India. And Sylvia knows Lindsay Jacks well, and this is a really nice slide of hers, I think, that explains how, as countries or populations develop, so from being poor on the left-hand side to being rich on the right-hand side, how patterns of obesity differ, and how the different risks for obesity differ for men and women, and for high socioeconomic status and low socioeconomic status. So countries like the US and the UK are in stage 3. Urban bits of some states in India are also in stage 3, but other rural parts of India in some states are in stage 2. Or even stage 1 perhaps. But as the country develops, these patterns of obesity change and the effects on men and women are different. So really interesting, clever way of describing what happens with development. So I'm going back to mention malnutrition-related diabetes, and this is a less elegant slide than Meredith showed that indicates the countries in which it's been reported. And we have been discussing how this type of diabetes might fit in to what we know of type of diabetes already. And so these are a few challenges that I think of as being important. So I've been talking a lot about the role of body mass index or leanness and how that's affected both by ethnicity but also by trends over time. So as you saw from that slide that I showed just now, that's a very old slide. A lot of those studies on malnutrition-related diabetes are really quite old now, and we really badly need newer data because the world has changed since a lot of the work has been done. These atypical forms of diabetes are a really mixed bag. We don't think they're type 1, we don't think they're type 2, they might be something in between, and it might be different in different populations. And then the overlap between problems with insulin secretion and insulin resistance will differ again in different people. And these are affected by a combination of both genetic factors and environmental factors all over the life course, including from before conception. And then, of course, over the life course, people's experiences change over time. So you might have been a very small baby and a very small, possibly even stunted child, but then if you get a chance to move to a food-rich environment, you might still be short, but you might have the opportunity to gain weight. So, for example, people might start not requiring insulin, but then develop the need to have insulin over time. And I think we've heard already as well that some of the tests that are needed to distinguish subtypes of diabetes aren't necessarily available. Many of them are not widely available in the UK, so I'm well aware that they won't be available in rural parts of other countries. And I think we've still yet to work out that many of these tests have been developed for use in European populations, and it may well be that there are other, for example, genetic factors that are more relevant to non-European populations. Angus talked about clusters, and he showed the Swedish data. The Chennai group also took this approach in a South Indian population to try and identify subtypes of diabetes. And they identified 4 subtypes of diabetes. And one of the key ones that I've highlighted here is the group that have severe insulin deficient diabetes. And this was over a quarter of their population who had very high HbA1c levels. And those are likely to include people with type 1 diabetes, but they might also include this malnutrition modulated form of diabetes. And here's the Swedish data again. And again, I've highlighted the wrong one here. I meant to highlight the one above it, the severe insulin deficient diabetes. And you can see the proportion of people with severely insulin deficient diabetes in the Swedish population was smaller at 17% than the 26% reported in the Indian population. But we think type 1 diabetes is much more common in Swedish population than in the Indian population. There's also, again, Angus showed this slide where this approach had been used in a Ghanaian population. And they identified about 8% as having what they called malnutrition-related diabetes. So this was a group of people with diabetes in Ghana that had very little insulin, as illustrated by very low C-peptide levels, and with very small waists. So they might be malnourished, or they might have type 1 diabetes, and it's difficult to be sure. So these characteristics have been put together to try and identify young onset, lean, ketosis resistant or protein deficient pancreatic diabetes. And Nihal showed these and showed how perhaps these should be updated now. But I think they provide a useful starting point to think about certainly people that should be excluded from this group, which would be people with exocrine pancreatic problems, and we heard the discussion about the role of antibodies. So I've just listed here the proportion of people that have islet antibodies in the group of people that are thought to have malnutrition-related diabetes. So in the Korean population, apparently 50% of people who were thought to have malnourished malnutrition-related diabetes had antibodies. But without having data for the comparison population, it's really quite difficult to make sense of them. And again, I think what's been said before is that microvascular complications are common in this form of lean atypical diabetes, and macrovascular complications are rare. I think part of the reason that the macrovascular complications might be rare is the lower levels of cholesterol, for example, lower risk of hypertension, but also perhaps the limited life expectancy. So I've now got some very difficult slides to follow, but I couldn't think best how to present these data. And so what I did was to try and identify some examples of studies where there have been estimates of the proportions of people with diabetes with what looks like lean atypical diabetes. So the Jamaican study has been mentioned already. So this was a study back in 1950s, before even I was born, and it was a study of 200 people with diabetes, of whom 13 had what was called then J-type diabetes, so about 5%. And there was interesting description of the characteristics. So there were similar number of males and females with J-type diabetes, and that contrasted with the male predominance for type 1 and a female prevalence for type 2 in Jamaica. And so I've just copied the sentence from the paper there. So in terms of age and body mass and mode of onset and findings on liver biopsy in these Jamaican patients, the people looked like people with type 1 diabetes. But they were different because they were they didn't have, they had more insulin resistance than type 1, but they didn't have any evidence of ketosis. Moving on now, so as you can see, the next studies are rather more recent. There was a study of deprived minority populations in, and I'm going to have to hurry up, I see, in Chicago. 13% of them were lean, but they had a higher prevalence of smoking, alcoholism, and pancreatitis that might be contributing to diabetes. And so I'll move on to the next slide rather than going through these one by one because of the time. These are studies of Asian populations and estimating the proportions of people with diabetes that are lean. So, and essentially I'm going to summarize this really briefly by saying less than 5% in all of these studies, the last three of the 5 are in India, and there's another one from Bangladesh and one from Seoul. So in India, less than 5% of people with known diabetes appear to be lean. So I'm now going to finish by just summing up that diabetes and obesity prevalence are continuing to increase globally. This is because a contribution of aging, urbanization affecting lifestyle and improving survival. Multiple different overlapping factors affect phenotypes of diabetes, and phenotypes vary between populations, and they're certainly changing over time. So I'd said the proportion of people with diabetes in India who are lean is less than 5%, but if we take the INDIAB estimate of 101 million people with diabetes in India, that's still 5 million lean people with diabetes in India. And it's important to know about these people because better understanding of the condition may affect treatment and improve their outcomes. And we've heard already about the challenges about primary and secondary prevention of all phenotypes of diabetes and the need to address undernutrition and overnutrition at all stages of the life course. It's time for me to stop. Thank you.